this is a discussion. We're taking lots of notes. We're going to basically grab anything you've also published or those. We're going to try to produce a couple papers and a series of presentations. We have a fixation in the Joint Economic Committee that if we don't start to move much more dramatically towards sort of technology disruptions, there's no path. We are the ultimate colloquialism canary in the mine in Washington, D.C. We are sort of the last voice in the federal government that is hyperbolic about how fast the debt is moving. Some of the participations in economic growth. We have built a thesis that basically is a unified theory saying everything from a talent-based immigration to the use of technology as a disruption to dramatic changes in how healthcare is provided just to stabilize U.S. sovereign debt. We are now borrowing almost $8 billion every day. That comes out to $90,000, $95,000 every second. And the model actually gets worse. In 9 years, almost a third of U.S. tax collections will go just to interest. Primary driver is demographics. You know, we often have our political biases, but the math, it's demographics. We got old, didn't have enough next generation. Your country is almost at zero population growth. How do the things, you know, so many of you have done that are not only impressive, but hopeful, how do we sort of socialize that concept and help people like me start to move policy fast enough? And we are genuinely concerned we're not moving fast enough. Look, Medicare Trust Fund is gone. Our math is in about 6 years.
Well, it doesn't make a difference because B and D aren't funded anyway.
Yeah.
I mean, that's the numbers.
Well,
it's about $600 billion.
Yeah, and then, you know, Part A, you know, are we just going to, you know, reach in and borrow it out of the, and we will.
Yeah.
Matter of fact, let's start with the smart people. Doctor, introduce yourself, tell them your specialty, and let's just go around.
Kevin Schulman. I'm a health internist by medical background. I'm a health services researcher, health economist here at Stanford at the medical school and the business school. And I run a master's of science in clinical informatics management program. And
some of your things you've been focused on?
Actually, where you just started, the math. So I have a nice CBO slide, which nobody understands, about the projections and the impact of mandatory spending on basically all of our students' ability to actually drive on the road over the next decade. Because if you look at where non-defense discretionary is, you know, they should. I keep telling them they should be out in the streets protesting every single day. But we look. Big chunk of my work is on administrative costs. So in the United States, we spend about 25%, at least 25% of healthcare costs on administrative costs, more than anyone else in the world. We spend more money to manage our healthcare system than France, Germany, and Italy combined spend on healthcare. Together with Josh, I'll talk about it. We've been looking at technologies, but also I run something here called Hospital Medicine Labs, looking at the micro level, how do we use AI to improve productivity of our faculty? How do we, through the master's program, how do we think about using technology to transform care processes? How do we rethink primary care as a digitally enabled service? So come January 1.
And it's that last line is one of the reasons we wanted you here. As you also do this, please, what are the barriers, particularly statutorily or CMS reimbursement, that I can go at?
So the moonshot one is no one's in charge of healthcare. There's no single entity in the United States in charge of the healthcare market. And so we look at Medicare, we look at Medicaid, we look at commercial insurance, we look at the activities of the health providers in the industry, but no one's in charge of the market, and no one's in charge of streamlining, especially the back end costs. A lot of what we'll talk about on the technology side is how do we create financial incentives, especially AI. AI is different than any other technology because it's iterative. So when Josh invented amazing technologies like a balloon catheter, it was fixed. AI gets better if we use it. We can figure out where it went wrong, fix it. And so we need to create financial incentives I think, and also sandboxes. Protect me from the downside consequences if I am a responsible user of the technology.
Back to that. Doctor?
Great. Hi, everyone. I'm Sandra Ruggles. I am part of the Stanford McLaughlin Center for Biodesign and run the policy research team there. We focus as a center on teaching and training healthcare innovation, and I know Josh will talk more about that as he introduces the center. The policy research team really looks at how federal policy impacts the innovation ecosystem. So the incentives for small and mid-sized organizations, both venture invested or privately financed. So we're looking at how do you incentivize innovation widely across healthcare and in areas of significant unmet need. So more about me, my training and background is in biophysics, and I started my career creating and fundraising for a biotechnology company, which eventually became a NASDAQ-listed organization. And then I've spent the last 15 years or so in medical devices. So I actually am here at Stanford about a day and a half a week, and then the rest of the time I spend with a consulting practice focused mostly on strategic decision-making in medtech.
Oh, I have 1,000 questions.
A foot in the real world, a foot in the policy world. So.
Okay, my name is Bo Wood. By training, my training is in political science, and I guess my academic work was all studying theories of the policy process and regulatory enforcement and that sort of thing. But why I'm here, though, is because now I work for the Governor's Office of Economic Development, and I run their Office of Regulatory Relief, which is what runs the regulatory sandbox program that Utah has created. And so, we have some experiences that we can share as to what has worked and what hasn't worked. Very excited about the idea of pursuing something like that federally. I mean, I think everything that you guys have said is absolutely relevant, that things are moving quickly, and being able to create a space for experimentation that is bounded and structured with exits and entry points that are clear, gives you information, which I think is maybe more valuable than the exemption itself. So I'm just excited to see where this goes.
Hey everyone, I'm Patrick McLaughlin. I'm a research fellow here at Hoover. I'm an economist by training, and my area is regulatory policy. I look at what sort of policies exist in different jurisdictions at the federal level, at the state level, in other countries. Are there processes for examining rules before making them and doing maybe a cost-benefit analysis? Are there ex post processes for looking back at rules and seeing if they're effective? Usually there aren't those processes. And then after I've done some quantifying of what we have and measuring different dimensions of it, I look at what changes could do to things like economic growth. Going back to your introductory statements, Chairman, one of the questions I'm asked by people like the CBO is, can we increase our growth rate by having broad regulatory reform, and will that solve some of our debt issues in the long run? And so I've got several studies doing simulations of that at the federal level, or looking at actual data, and then also looking at places that have deregulated or instituted broad regulatory reform and seeing what the growth consequences, positive usually, are for doing that sort of thing. So and Kevin, some stuff that you said really resonated with what I'm currently working on. The question of whether someone's in charge of one narrow aspect or even the whole regulatory policy that's instituted in a jurisdiction is something that I am often looking at the state level especially. Is there someone in charge of making sure that if there's some sort of regulatory reform that is implemented, that the regulators are doing what the governor said they should do, for example. And the other one is fragmentation. This is well, two other things. Fragmentation, when things are spread across multiple regulators and you're a company dealing with them, they can contradict each other. And that's increasingly showing up as a big problem for innovation and growth. And then discretion, how much discretion is built into the regulator's purview. Try and find ways of measuring that. And where we do see it turn up, we're finding that be a pretty major issue as well. And you would think that post-Loper-Bright, that the amount of discretion that regulators have is somewhat constrained, but the statutes are still there that give regulators broad discretion quite often. We saw it just implemented in a court case that came out yesterday, where the enabling statute talked about the regulator being able to regulate as necessary. Those are the terms put into the statute, and that just gave them really free rein to do what they wanted to do.
Was that a state level or?
That was Federal Circuit Court.
Okay.
That was for the two-person crew size rule from the
Got it.
Federal Railroad Administration.
Got it.
Yeah, there's not really a safety justification for that rule, but they have the discretion to make
There's
it
a
anyway.
thing called a union and lobbyists.
Exactly right. Yeah. So that's my area.
All right. You know what, one of the most intimidating thing? I'm the only one sitting here who didn't do a PhD.
Well, I am another PhD. My name's Allison Okamura. I'm a professor here in mechanical engineering and computer science and a co-founder of the Stanford Robotics Center. So I am a roboticist. Let's see. So while my main specialty is working on making and designing and controlling robots for the last few years, I've been involved here at Hoover as part of their Stanford Emerging Technology Review, writing summaries of the field of robotics and trying to make it accessible to the general public and provide useful, hopefully, information to policymakers. And I'll be a senior fellow at Hoover starting next month. So let's see, the things that I think about in robotics, in full disclosure, I am not a regulatory nor a policy expert at this point, but one of the things that I'm seeing in the field is huge need for data. Just like large language models, ChatGPT and such are driven by data about text, which was already readily available and make those systems so capable. The next wave of robotics will likely be driven by lots of data acquired by teleoperating or puppeteering remote robots. Data, for example, from Waymo cars comes from information they collect as they drive around. And to bring up a medical example, a lot of my work is in medical robotics. Intuitive Surgical, which is a company that makes a teleoperated surgical robot, has millions of hours of data of surgery that can't be used for training autonomous robotic procedures that will be needed in the future. And so one question I have is about the ability to collect and use data. How do we respect privacy and safety, but at the same time get the data that we need in order to jumpstart the next generation of robots? Another question that I have is about the relationship between robotics and jobs. How does regulation affect that trade-off? Of course, there's a huge narrative right now about robots taking away jobs, but I think there's obviously a Yeah.
Sorry, I know I'm interrupting. We push back fairly aggressively
Yeah.
on, we think we have the labor shortage and our demographics. We don't have a choice.
Yeah, and so exactly. And so the extent to which regulations impact our ability to get robotics both developed and then placed into scenarios where we can cover areas that where we're really having trouble finding workers, ranging from healthcare to manufacturing. These are going to be really critical, especially for onshoring and reshoring activities. So those are just a few things I'm thinking about. Happy to answer questions, especially from a technical point of view about robotics.
Good to meet you. I'm Josh Makower. I'm a physician, engineer, entrepreneur, investor. I've started multiple medical technology companies. And I co-founded the Biodesign program here about 25 years ago. And as Sandy mentioned, we focus on training the next generation of innovators to enable them and give them a process that they can use reliably to invent and create solutions to the biggest problems facing patients today. So we're really patient focused, but we give them a methodology, and we train business, engineering, medical students as well as faculty here at Stanford and faculty across the world. And we've, kind of created this program. Many countries and places across the world are actually using this program as a economic engine to create sort of a business sort of ecosystem around medical technology. That's inclusive of biotech, med tech, digital, and diagnostics. So I co-founded this 25 years ago, and with my co-founder Paul Yock, who's a famous interventional cardiologist. We worked together over the past 20 years. I came on full-time as a professor here 5 years ago. And when I did, we initiated this policy program that Sandy and I and Kevin all work towards. The goal of our policy program is to focus on the ecosystem and really trying to identify policies that would enable the ecosystem to successfully address challenges, cost challenges, healthcare challenges with individual patients, or even just to create a robust ecosystem that that can grow and robustly help the economy, help patients, and also create a platform for U.S. economic sustainability and competitiveness. So that's sort of our focus. All the policy work that we've been involved in thus far, and my work in policy goes back to the Food and Drug Administration Safety Act, where I played a pretty important role orchestrating the various stakeholders towards policy and change in FDA that has enabled, I think, a lot of the progress that's been made in FDA over the last 10, 15 years. But I think there's an opportunity now for really revisiting, and especially on the reimbursement front. And right now, as you look at where is the major roadblocks for innovation, we have substantial challenges in sort of coverage, coding, and payment. That is really putting a damper on the ability for innovators to get their innovations into patients' hands, to be paid for their innovations, and to actually realize the benefits that they are proposing to offer. But today there's a substantial multifactorial blockade on those innovations actually reaching patients. So I'd say a lot of our work at the center these days is focused on sort of trying to find thoughtful policies that unlock that access for patients early so that we can see their benefits. The good ones can survive and go forward. The ones that are not working can be set aside. But instead of just creating a roadblock to all innovation, which is sort of where we are right now.
3 quick things,
Yeah.
and I know this is out of order. Help us with almost more of a granular, as you're going along, saying, here's the policy, here's the law, here's the CMS rule.
Right.
Change it this way.
Yeah.
As we've been playing on our side, trying to come up with almost a federal sandbox model.
Exactly.
For reimbursement. I've done some stuff for my state on a sandbox. Utah has done a brilliant job. I'm jealous of them. That's number 2, high level of sensitivity to the passion to find things that save money. And number 3, how do I get people off their backside to show up because there's no free options? You come up with a new technology, robot to remove my appendix, and there will be an army of lobbyists from the incumbent model to stop you.
Correct.
And folks do not understand Congress is a protection racket, and it's a protection racket of incumbency, not elected incumbency, bureaucracy, and business incumbency. I cannot tell you how much lobbying I get. I'm number 4 in Ways and Means. I have oversight. I joined Economic Committee. How much my life is dealing with brilliant, articulate, well-dressed, and overly paid lobbyists to stop you from innovating because you attack their business model. And the pressure right now may be on your side if it changes the cost. And we'll talk a little bit more, but there's amazing examples of the amount of, a dozen years ago, I had lobbyists in my office trying to slow down access to a hep C cure because they had invested in liver transplant centers and they wanted to slow it down. Same thing with GLPs, glutites, because you'd be shocked how immoral and mercenary. So, hi. And you get to do, because I'm going to both have you introduce yourself, your specialty, and then we're going to go back the other direction.
Okay.
And you're going to tell us what you would have the brain trust in Washington change to make it so your ideas can succeed.
Let's start with what do I do? And then we'll get to what can change. Some crossover with other folks, but my background is really in energy, nuclear energy specifically, fission, but more broadly over time. My first job was actually supporting the nuclear Navy, doing shield design. Then I came out here, I was a professor at Berkeley for a while, computational methods and supercomputing. And I went on loan from Berkeley to ARPA-E. And I started the fission portfolio there, agriculture, cement, all kinds of different stuff. Came back here, ran Cyclotron Road, an early stage hard tech incubator out of Lawrence Berkeley National Lab. And now I've been at DCVC, a deep tech venture capital firm, for 4.5 years.
And the firm specializes in SMRs or what?
We specialize in what we call deep tech broadly, so using large data AI compute to drive advantages of companies. So my specialty is in really energy, but things also proximate to energy, critical minerals, some transportation. The firm does way more than that. We actually do a lot of tech med, tech bio, space, compute infrastructure. We do a whole wide range of things. Rocket lab, spine surgery robots, a whole range. Fission is my real expertise, but I've also invested in fusion, geothermal, long duration storage, critical minerals production. So a whole range of physical technologies driven by AI and compute. And so we're thinking a lot about how do we move things together forward more quickly? What are the regulatory barriers? Some areas that's much more affected than others. But also looking at labor shortages, and should we invest in technologies like automating solar installation? How can our companies have factories of the future where there are 0 to few employees on site and it's lights out operations? We also look at, we looked at an autonomous train company. So FRA regulation was a big focus of our diligence.
That's actually one of our fixations.
Okay, yeah, so we spent some time in that area. But really, right now, nuclear is having a moment, so that's probably where we're spending the most time. And thinking about sandboxes, there were executive orders last year trying to change some things and make things move faster. I would say that was somewhat effective. Some things were helpful, some things were really more political wins. I think thinking about solutions, it's, yes, people need political wins, but how do we make sure those are actually aligned with real wins?
You can use the term theatrical.
Yeah. Yeah, how do we make sure the substance matches the theater? And I do think sandboxes can be really helpful where you can try things out and have a bit of a safe container. But I do think it needs to be connected with how do you tell what worked? How do you translate what worked into real policy? How do you both move fast enough to make a difference and slow enough that you're learning? Yeah, it's a hard trade-off.
Is the learning curve, as you talked about AI, is the learning curve dramatically changed?
So it depends. So there's yes, the learning curve has accelerated, but there's still limits to how quickly you can build physical systems.
Yes.
And you have to, and to see, did this policy work? You know, you sort of have to get a few steps in to tell.
Biggest barrier you face on delivering innovations?
It's probably the fragmentation of policy. We do a lot of stuff that interfaces with the electricity grid. So maybe that's the clearest area for us, where local policy, state policy, federal policy, FERC, PUCs, like it's all just a big mess. And so trying to figure out what are the technologies that can either not have to deal with all of it, can have a pathway around it. It's sort of like, how do you find something that you can deploy commercially that doesn't have to deal with the Gordian knot of regulation while you're simultaneously plowing through the Gordian knot of regulation? And so that's a lot of people are doing, you know, private installations or behind the meter or things. It's sort of like you have to keep your company alive and keep developing your technology while you're sort of plowing through the morass.
Solution?
I do think the sandboxes, how can you pilot new regulations and policies, especially new technologies often are safer, they often are lower impact, and so you need a place to go prove that out and measure it is safer, it is lower impact. And now you can update regulations that were written for something that isn't what this is anymore. And so that's, to me, the value of sandboxes, is your regulations are written for something in the past. And so if you can prove out the value of the new technology, you can update the regulation to reflect the new risk.
That's one of your areas of expertise, is future-proof a smart regulation.
And if I can jump in on this a little bit, I think one of the issues with sandboxing is, well, if you sandbox at the federal level, you still have state and local stuff to deal with. And I don't know if there's a way to coordinate sandboxing across the whole layer cake of regulations.
And the most of the sandboxing we've looked at is trying to mitigate some of the tort liability. I cannot tell you how many innovations, particularly in some of your medical, it's, oh, we want to do it, but a 10-second example, breath biopsy. Professor came to me almost 5 years ago, built a thing she calls a flukazoo, you know, remarkably sensitive, and said she can't get investors in it because both the regulatory environment and the tort liability, you know, trying to get and reimbursement, you know, and its real economic value is, hey, we recognize you have a viral infection, we want to order your antivirals. That ability for it to write a script is its economic value. And, you know, 50 plus territories would say no. Yet the technology swears it's statistically within the abstract as accurate as a human doctor.
So why wouldn't it, I mean, it seemed like the approach that we've taken, you know, allows for, I mean, ours is a single company, single entity over a very limited period of time, you know, 1 year, extendable for 2 years, but you're not exposing the entire industry to
And
to
you may be,
liability.
but that's one of the reasons you're sitting here, and we're enthusiastic about you stealing my sandbox legislation. I wrote one for distributed ledger, but for Arizona a decade ago, and
I didn't steal it.
no, you,
It
no.
wasn't me personally.
But in some ways, if she had a new power model, a new bus battery, a new something that could be put on the grid.
Yeah.
But you also have an additional regulatory body for your utilities.
The PSC.
And she go and load that energy technology in Utah and use your sandbox?
Well, the way it would work, if somebody, I mean, we've got a project now that we're working on, the inland port, that's a whole other thing that we've created, right? But they have their own project areas, can declare a project area, and then that, they passed a law a year or so ago that allows large load customers to produce their own power behind the meter, but they set the limit at 100 megawatts. So if you're wanting, this inland port group, they want to be able to develop this project area. Rocky Mountain Power can't get the power to them for 5 years, and so they want to do their own, but they don't want 100 megawatts. They can't use that much, and so we're working on a sandbox circumstance that would allow them for this project area to have private power generation, and then in order to do that, the PSC would have, in our law, they have regulatory veto power, but one of the things that's valuable for us is that the legislature's been very clear that if there is a less restrictive way to do something, that the regulatory agencies are encouraged to find a way to say yes. And I think that would be the trickiest part at the federal level, is you've got entrenched bureaucracies that have, their own ways of thinking about things. And how do you, especially if they, if their perspective is not consistent with the current administration, how do you get them to enforce what you want them to enforce? And I don't know, there's been discussion in Utah about waiving, about removing that sort of veto, that they can veto a sandbox application, and
Isn't that in your state constitution?
no, there's no, I don't.
I mean, the regulatory body. Your corporation commission.
Oh, the PSC, yeah, no, but they could take out of the statutory provisions for the regulatory sandbox, the provision that allows whoever the regulatory agency is. Right now, they have to issue an opinion. And really, the only restriction on their opinion is that it has to be signed by the chief executive and it has to be made public. And so if they can come up with a public reason why, that sandbox application is not viable, then they can veto it and I can't override that. But
then now you have so you're going to reach out to some of your investors, and are they willing to take that type of risk?
It depends. I think it depends on what they're trying to do and how likely it seems to get vetoed. I mean, it sounds like,
well, so far I don't think we've had any.
yeah, so it sounds like the
I mean,
likelihood
in
is
Utah,
relatively
that's
low.
why, about Valor Atomics, that's why they chose there, right?
Yeah.
Is because of that exact thing, because the path to market is fast. But I don't, I've thought a lot about how do you replicate that at the federal level? There's so many more moving pieces.
And there are, to the fragmentation point,
Yeah.
there are state by state, behind the meter is being addressed state by state right now. And it's like you have to go get a law passed in that state and build there. And then if you want to go to a neighboring state, you have to go into that state and get a law passed. Like, it is very slow.
All come to Utah.
I'm not sure that the federal government is so calcified intellectually anymore. You might be better off doing it by state.
Well, you could do those mandate
but-
cooperation.
Yeah.
You could simply direct, through executive order, you could direct agencies to cooperate with their state counterparts, because a lot of the times we'll have people that will approach us and say, and it turns out that the barrier is federal. And, simply having direction from the executive branch at the federal level that they are to cooperate with us and to try to find a way to make it work, that would carry weight and would be feasible.
Aren't investors going to worry that that's going to get reversed in a couple of years
Well,
post
yeah.
next election?
I mean,
Yeah, it's
of
the
course.
visibility problem.
Yeah. But I mean, if you can, the more successes you can point to and say this actually moved the needle, this was a thing, it worked, that helps. I think that helps to retain that. I mean, people tend to like to keep what works.
Yeah, the more victory, the more projects that are underway, the harder it is to reverse something. Yeah, but like Fervo is taking advantage of the.
Yes, absolutely.
When I hear something where you talk about going state by state, it immediately triggers in my head some of the issues that we often hear about through our pediatric medical device incubator called Impact One, about getting new pediatric innovations to market, where again, all of the decisions around coverage and payment are handled at the state level, because most pediatric populations are Medicaid populations.
Yeah.
And so not only are you talking about a smaller population, so potentially a less attractive market, there isn't a single payer in the form of Medicare to make a single decision that can be nationwide. You have a state-by-state challenge. And so I love the idea of like at least seeking opportunities for cooperation, collaboration.
A Medicaid certification that's universal?
Well, not potentially, but I think even there's an example, CMMI, for the very first time that I've heard of, actually has an innovative program for pediatric patients called
Yes.
Aspire, right? That's the first time I've even seen them move into the pediatric populations versus always being centered entirely on our 65 plus paid through Medicare patient population.
It's, okay, now that is.
Even giving more of a prescriptive mandate to think more broadly, to Kevin's point, about the entire US population, not just our Medicare beneficiary population.
And that's going to continue, though. The Medicare population is going to continue to consume everything in its path. Look, we have some math that basically says in the next year or two, fewer under 18 than we had 25 years ago, but almost double 65 and up.
Right.
The demographics brutalizes.
This is really amazing discussion. One of the challenges that I see all the time is no one understands the math. I mean,
Welcome.
not one candidate on either side.
He's now my new best friend.
Yeah. I mean, but
It's worse than, okay, this is absolutely self-serving, and did I mention I've also had a stunning amount of coffee already?
yeah.
Both Republican and Democrat administrations, because I annoy all of them, my fellow members of Congress, the lobbying community, and a lot of the think tank community don't like the math because often the math doesn't fit their pitch. I think you've gone through some of that where we have a running joke at home when I'm insane. I have a 4-year-old and a 10-year-old we've adopted, and my wife's my age because we wanted to screw up her retirement. So I care a lot about. Daddy's on his way to go work in a math-free zone. But the team, we go through this all the time. We do these presentations on here's the math, and we get vilified for telling the truth. And sometimes it's not just the administration, not fellow members of Congress. It will even be outside groups saying, don't tell people that. You're scaring people. Or
Scared.
Yeah.
But it's one of the reasons we were giddy to come to Hoover, and many of you that are becoming full staff and those, we need you to evangelize math is math.
I mean, the government of France fell 3 times last summer when their deficit got to 3% of GDP, and ours is at 6.
No, we're right now running 7-4.
Oh, great.
7-4.
We're doing a good job.
Am I fair in that?
Everyone should get a
Sorry,
raise.
I have a fix. I'm not very smart, but I'm freaky good at math. And it's terrifying.
I mean, there's the macro picture that you literally people should be in the streets. Like every student here on campus should be protesting every single day, like they did in the '60s. They will have no future at this rate. It really is that dire. I mean, when you look at the projections of mandatory spending versus discretionary, and that doesn't include non-defense, like there will be no money for roads. We're just going to be paying interest and Medicare. That's what the federal government's going to do, and defense.
Robert.
I totally hesitate to bring this up because it's charged, but it seems like if this is all correct, which I agree that it is correct, you've got 2 choices. You cut stuff or you expand the pool of taxpayers. And it seems like a lot of our policies, I mean, there are people that would love to come here.
It is,
And we're not taking advantage of that. It seems like that is a path forward that we've constrained. And
I
just don't
know I'm interrupting, but I need you to think grander. I am fixated on the concept of a unified theory. And I've been working on this for 15 years. And remember, I'm quitting Congress because I'm not allowed to strangle the people I work with. I'm tired of being angry all the time. I need a talent-based immigration system. I need a path for radical adoption of technology. I need to dramatically change the incentives in healthcare, that it's health, not structures. I'm going to have to take Indian Health Services, VA, Medicare, Medicaid, everything else, and somehow put them under a sort of a capitated model where the value is health, not, scoring people. I mean, but it's from up and down. And too many of us, particularly in the research community, you're brilliant. You're obviously, you wouldn't be sitting here if you're not a genius, but we maniacally fixate on our area of expertise and not appreciate the interactions of, if he fixes the regulatory and we fixed some of the healthcare delivery model, and you came up with, my way of taking a rural community and they have a surgeon, it just happens to be technology. They all interact. And we keep wanting to do our one silo. And the interactions, I don't get the actual economic benefit. So let's have a little fun. You met with, was it Penn Wharton or Yale budget model?
Ben Wharton.
What was in the most dystopian model? So let's go to the really, how soon did they?
No,
think
they're
we-
average.
They were like 14 years we hit.
22. Yeah, it could be up to 14 in worst case scenarios, but yeah, we will hit default zone in like the late 2040s.
Default on the debt?
We don't have enough tax receipts available to cover our interest coverage.
Right. Assuming the interest rate stays where it is.
Oh,
Other of obligations.
in my model, I'm a little more dour, and don't blame the joint economic economists. 9 budget years, so 10 years from now, almost a third of US tax collections are just interest.
So part of this, so we're starting a discussion here just on healthcare. So like healthcare is a chunk of this, right? And we've got obligations to seniors. We've got challenges with the private system, with commercial payers. And so the current structure is not working, for Republicans or Democrats. It's like the number one issue out there. So how do we tackle an issue that big? And we've kind of broken it down into a couple of different things. One, the administrative cost piece alone, it's not great in terms of scoring from CBO, but it will encourage economic innovation.
Let's attack that. My state develops a sandbox that allows me to use, and we actually have had legislation on this for 7 years, and I will never ever get a hearing on it, that would allow, here's my doctor's notes, here's the insurance contract, auto pay. Basically, the automation. Surprise billing no longer has it's notes, insurance contract, auto. Can I build a sandbox even at my state level that would automate much of that back office?
Yeah, we've been talking with actually a group at Intermountain, the Mindstream Institute, about this. So Turquoise Healthcare in San Diego is actually building an open source computable contract between health plans and payers. Providers and health plans. The prior auth stuff, we could talk about it offline, I can't make heads or tails of the notes when my residents write them. I don't know how the health plan's gonna read the note. that's a different issue.
Well, I have a more radical, like my new best friend here, who's wearing an Apple Watch and an Oura Ring. She has enough data coming off her body to probably, I mean,
Yeah.
I'm
But
fixated
we-
on wearables.
But in terms of the core of dramatically reducing administrative, say, we could take $1 trillion out of administrative costs. Not all that's gonna flow directly to Medicare. Some of it, if we calculated it, some of it's tax savings, because if we pushed it down to reducing premiums, then the tax benefit from employer-based insurance would go down, or the cost, tax expenditure should go down. Everyone would, have easier access and more predictable costs from getting healthcare services. So I think there's, at least on that side, the path
Okay.
forward.
So give me, and I know this is brutal, give me a paragraph of legislation, policy. What do I do to affect this?
Yeah, so actually, when we had a meeting here about it a year and a half ago, a lot of people here like the idea of a Federal Reserve type entity in charge of transaction processes in healthcare. So raise it up, like if you got one shot on goal, let's have someone in charge of, not in charge of what the benefit is, because everyone will fight about that, just the payments. Like, who's gonna set up the computable contract? Fannie Mae and Freddie Mac did this for mortgages. We have one entity that sets up a transaction process. There's a computable contract. United Healthcare can't fight that their thing is better than.
So I'd set up a
Aetna's or
version of a rep and warrant on a healthcare insurance contract, so everything's standardized.
Yeah, everything's standardized. Why, just in Medicare Advantage alone, right? How many gazillion, we just did this, looking at provider manuals from 3 different health plans in the commercial market. There's no rhyme or reason to any of this prior auth stuff. I mean, it's just a way of generating money for somebody somewhere down the rabbit hole.
Welcome to my world.
And the coverage policy landscape is just a thicket.
Yeah.
Right? There's no way for patients or providers to determine for this patient with this plan, what's the coverage for especially for new technology. We've been looking into this in terms of coverage policies for new innovation. And across the board, it's just a thicket is probably the best way to describe it.
Give me a little more on that.
Can I ask a naive question? What do you potentially lose by having the standardized contract? Like, what's the variation?
Customization.
Yeah, we lose all the innovation that's occurring right now in the healthcare market. But we have 318,000 different health plans in the United States. I don't know we need that much innovation at the cost that we're spending for it. There's no data to support, so we can make a computable contract. So you can add something to your contract that's not in my contract. I don't really care as long as it's code. Right now, all the innovations become manual and are on Excel spreadsheets.
The standardization is just making it computable, not making it the same.
Medigap covers 70 million people, and there's just like 8 or 10 plans. For me, I would choose, let's choose 10 different things. I don't really care. I don't know why you need more variation than that. But in theory, you could have as much variation you want as long as it's computable and immediately adjudicable. So in the Netherlands, for billing for the same service, and it's a private multi-payer system, they pay 1/10 the cost that we do per transaction.
More predictable you can make, how do new technologies slot into the system? How do they get coded? How do they get paid? The easier it is to invest in them and the easier it is for them to move forward, because that is a barrier.
I mean, I think the rule of thumb that we teach the fellows at Biodesign is that reimbursement, so coding, coverage, payment, the 3 pillars of how healthcare technology gets paid, that is your business model now. You have to understand how that works because it is the critical hurdle to actual diffusion of innovation.
Who gets paid, and is the person who's getting paid the person in charge of bringing your technology
Oh,
forward?
well, that's, yeah.
That's the other part.
Healthcare is a special space because no one is 100% accountable for decision-making or
But
payment.
that's the other, when we look at investment opportunities, it's who has the motivation to even push this forward? And if they don't, yeah. So it's
Yeah.
just a lot of things to align.
So a state like Arizona that uses a capitated model for our indigent our Medicaid system is a capitated model. Does that make it easier to say this technology gets to be used in Arizona and it will be offered by the individual plans?
So I think the challenge for new innovation is often the threshold of clinical efficacy. So Medicare is statutorily only allowed to pay for services that are deemed reasonable and necessary, right? So what's happened over time is that reasonable and necessary has moved further and further away from the FDA standard of a reasonable assurance of safety and efficacy. And as they move further and further apart, the cost and expense of developing the clinical data to demonstrate it is ballooning. And as you automate more of the coverage decision-making, there is 100% refusal to pay for anything that does not meet that threshold. So you have what we call the valley of death between when an FDA approved or cleared product comes to the market and how it meets the threshold for being reasonable and necessary. So we looked at coverage policies for codes, technologies coded by temporary codes. They're called T codes or category 3
yes.
codes. And we've been working on some research about whether Medicare Advantage versus traditional Medicare pays for those technologies. And what you see is in the absence of Medicare coverage determinations, it's like 99 out of 100 of the Medicare Advantage policies are negative. So it shuts the door on any innovation because it's not proven and it's not gold standard yet. And so therefore, it's not payable.
And the bigger problem with this delay is it breaks the venture model.
Yes.
Most of these innovations are funded by venture capitalists. That's where most of the innovation is coming from, early stage innovators. Those funds have a 10-year life. This pushes, an additional 5 or 6 years after approval where you really don't have a business yet, which needs to be supported by somehow the venture community because there's no payment. There's no actual reimbursement. It's a very slow build, so you're really not in business yet.
So how do you change that without also creating huge leakage of spending?
Well,
Or even leakage at all?
Yeah. In the earliest day, so the thing that we always point to is there are many regulators on adoption. The biggest of which is physicians choosing to use that technology, learning the technology, finding the right place for it. The cheapest time frame for a technology to be supported is when it's first actually being introduced. So, CMS just recently introduced I think responsive to this groundswell of concern over this issue, this program called RAPID, which it just got released and I need to study it further, but it seems to go towards the same thing in some respects that the two bills in the House and Senate are going after with accelerated coverage for Medicare breakthrough products, which is to create a opportunity for a guaranteed coverage for things that qualify as major breakthroughs that are really advancing healthcare and basically give them a confirmed period during which they will be paid for by the system, but they have to prove that during that time frame they have to deliver evidence that they're living up to their expectations, both clinically and cost effectively. So that seems to be a potentially reasonable pathway to enhance innovation. It's only really going to be for a very small group of innovations, but it's still a hopeful it's in a way, it's like a sandbox in a way. It's creating an opportunity for these innovations that qualify as breakthroughs to get a certain amount of funding for a while they prove further, while they bring further evidence.
You have to make it so there's a threshold, either it saves money, extends, efficacy on health or life, or assume those are,
Well, I mean, to qualify for a breakthrough, it has to be something that addresses a population or a disease state that is really underserved and has substantial suffering and, loss of life, loss of, significant health consequences. So there is a threshold for sort of admittance into that program based on the breakthrough designation.
On the FDA side, and this is, I advise a bunch of student companies and have some stock in them. FDA still regulates medical devices by indication. And the problem is AI is not an indication. And so literally, like, you have a diabetes app on Friday and you put a couple more lines in the software code and it's a hypertension app on Monday, that's an entirely new approval.
True.
And that goes to one of the other examples that we put into the written statement, is that there is another good example of a combination of what I would call an active sandbox versus a passive sandbox. So the access and tempo programs from CMS and FDA. So you're seeing two parts of HHS collaborate together to create a space for a mechanism to bring digital health therapies that don't have a defined benefit category forward under a per patient per month style of payment, and they're taking that access program and coupling it with tempo, which is FDA enforcement discretion. So it's easier to get your mind wrapped around all of this by looking at the first product to be authorized or to be admitted to the tempo program at FDA. So that's a continuous glucose monitoring device. It's a software that goes on top of that from Dexcom. And it's a glucose health program.
I was actually at the Dexcom factory yesterday.
Okay, so it's a software program that goes on top of their wearable platform and their medical device platform with the CGM, and it's a glucose health management program. And when you read the FDA documentation, you can almost see what indication for use they're allowing, which is for the management of patients with metabolic dysfunction and the diagnosis of prediabetes and diabetes through this software. So it's FDA giving more leniency to these rapidly developing software tools, but they're on top of, I think, medical device platforms with the risk and quality management systems that require the safety reporting and the follow-up, and in particular, access requires clinical evidence collection, real-world evidence collection, alongside the payment model that comes with being able to experiment with these digital health technologies in patient care.
So as a thought process, like, to go back to Arizona, and it's January 1st, and I want to do a program for everyone on Medicaid. And I want to give everybody a digital doctor. Okay? In terms of economics, that's going to be a winner. But if if the patient's got diabetes, then I got to get diabetes approval. If they have hypertension, I got to get hypertension approval. If they have heart failure, I got to get heart failure approval for the same piece of software. I mean, so at some level, and actually this is not a new problem. I talked to Bram Zuckerman about this like 2 decades ago. There's certain things that I'm concerned about AI. Assuming, like, if AI goes haywire, it's going to do this, that, the other thing. This kind of AI is dangerous because as a academic, I have no idea which devices failed. Like, because no one publishes that. So I'm assuming the FDA, I'm sure they've seen some really horrible things. I did the first clinical study of a CGM monitor 20 years ago in New England Journal of Medicine. I did the stats on it. So this is taking forever to come to fruition, to have a total closed loop pancreas. It doesn't, the technologies move forward. So if FDA is worried about software doing X, just come up with a list. Like, don't do this. Don't have this kind of, software. I want to have an adverse event button. Like, if the thing makes a mistake, press a button and somebody has to address it, the same way we have adverse event reporting with drugs. But indication by indication is going to really slow us down.
What you're saying is maybe defining the risk tolerance of, like, if you want to pilot something in a sandbox, instead of specifying what it can do, it's more like specifying the risk level, like what it can't do. It's like,
Yeah.
what are you willing to tolerate and what aren't you? And that maybe goes back to a lot of these things actually are lower risk, and we're not regulating that way. So how do you prove it out if you say, as long as it's not, if it's inside of this consequence box, let's see what happens, go collect data.
Well, and coupled with that, like, to get into the sandbox, you have to meet a certain performance threshold around, say, cybersecurity or privacy, but you create a checklist that says, as long as you meet these things, right?
Not
Because-
any nuclear reactor should get to turn on.
Right,
Exactly.
no, totally clear, but also you
There
should
goes my
allow,
basement project.
but we're trying not to incentivize just the well-capitalized incumbents to be able to play in sandboxes, right? So a small company where everyone's wearing 45 hats on the development team, you have to have a very prescriptive set of requirements for them to be able to participate. And as long as it's really well-known, here's your checklist, meeting the following standards, safety reporting of a specific type, or a dashboard that's built in it. I like the model in Germany for digital health tools from DIGA, where they have a performance-based threshold that's linked to payment, and they have to have a regular reporting on their clinical outcomes, their safety, all of that, and they don't even release 20% of the payment unless there's appropriate reporting that's happening through the dashboard. So, that linkage between payment and reporting, payment and evidence collection, I think really stands has a strong threshold for value in healthcare.
Who's the best in the world right now at digital health?
I want to hear Kevin's.
I don't know. I mean, I think it's happening every day.
I mean, you have a lab here at Stanford, I believe, that
We have-
was working on wearables, and, I mean, it's been a year or two, but I read one of their papers.
Oh, we have lab, so I run a lab in hospital medicine, how we improve productivity of the docs in the hospital. Josh has got Biodesign, where they've been doing wearable sensors for more than a decade. There's all kinds of different applications of AI. We have radiology, we, even here internally, even for, moving things into clinical production is a challenge that might be unique to Stanford, because there's so much coming at us at one time. But it's really this question, like, how do I understand, does this thing work technically, and is it safe? And then how do I help it prove out?
One area that I think, so there's a lot of existing technologies that play different roles, but there's one big space where even the FDA has not figured out how to regulate, and that is where AI is making clinical decisions. They really are, the full mandate is only on things that can be qualified in a review process and then predetermined change control thereafter. But generative AI is sort of outside the box, and they have not figured out how to regulate it. This is what's sort of exciting about the Utah opportunity. I'd love to see that more expansive beyond just sort of refills. But there is a really timely opportunity right now, as we look to reduce the cost of healthcare, improve access, to figure out some, federal way outside of the existing FDA, structure with the 510Ks, PMAs, et cetera, take it outside of the medical device pathway and create a unique pathway that's going to incentivize innovators to create decision-making
But
software.
when Apple went and had their
Right.
new generation watch, it's FDA approved for the heart, they did sort of create a third rail.
Yep.
Of a path.
But it's still very
Yes, it's
seated
very
within.
narrow,
Still
and there's really
indication
only.
by indication still.
Yeah,
Yes.
and this is actually one of my fixations. And this is actually where we were partially thinking of trying to give the FDA sort of a federal sandbox was that model. But, okay, so I assume that's one of the newer Apple Watches on your left arm. Should it, if it has an FDA approval on this area of heart, should it be allowed to prescribe within its area of competence?
Well, I mean, I don't know whether that's.
No, this
particular.
is the thought experiment, but that was the drafting of, we were trying to do on the concept of a federal sandbox was, and the real reason I was playing with this was the capital stack. I'm trying to figure out how to stop the valley of death because the regulatory wall is so high.
I really do think there's a very big opportunity for decision-making, both administratively as well as, clinical decision-making. I believe there's a broad swath of clinical decision-making that's fairly, algorithmic, formulaic, and could be, could lower costs, improve access, give any patient with a cell phone the ability to interact, and clear guidelines for escalating to, human in the loop,
Yes.
And to enable a range of conditions, that you could release over time that would further increase the bandwidth for this, agent to be taking care of people's health. I think it exists. And the technology is here, but there's no clear regulatory payment model. There's also no clear liability and other frameworks to protect patients and to hold, the companies that are creating this and or the ones that are deploying it accountable.
So help me try to sound smarter than I am. I talk to Oz every other week, and the number 3 person over there is a former staffer of mine. So I at least get my calls returned. How do I hand them, and I find I have to put something in writing because there's a lot of former insurance people and those things who are now in the bureaucracy over there, so most of our ideas are heresy.
Yeah.
What do I give them?
Yeah. I mean, Sandy, in the written statement, I think we have a few suggestions on this front, right?
Yeah, I mean, I think I think some of the things that CMS is doing around creating sandboxes with capitated payments. So organizations can move out of a space of billing for every single
That was,
interaction. Right. So creating models that allow for intensity or interaction, I think, is important, because when you see and hear about technologies where patients are directly interacting with it, there's kind of a hockey stick. You have a certain percentage of patients who are really heavily interacting with that, and if that were something that billed every single interaction, you'd end up with billing through the roof. So there's a fiscal responsibility element of it that allows people to interact more frequently.
Can I chime in with quickly the role of the time scale? I think is really important, right? If you're having a dialogue with a AI psychiatrist, that's very different from getting a prescription and then potentially having it have layers. And to bring in robotics, the next decision is about how to move. That's a totally continuous behavior. And so there are going to be some scenarios where the time scale is one where you can put these layers of safety, and then other types of interactions, whether they're text or physical, you won't
Yeah.
be able to do that. So just wanted to highlight that difference.
Can I
Yes.
walk
That's
through
great.
a scenario, and this may be juvenile compared to where your intellects are. We did some math experiments. The majority of people in my state's Medicaid system, so about 28% of the population's on my state's Medicaid system, the majority were obese. A disproportionate share were morbidly obese. Just as a thought experiment, we played with the idea of taking a part of my population that's morbidly obese, they happen to be huge users because of multi-chronic conditions, and say, we're gonna put a wearable on them, we're gonna actually gamify part of this, that even down to the pill bottle cap, when it's open, we know you opened it. Hitting the data set, we can actually, many of these populations are on an insulin pump, we can actually see insulin monitoring, and gamify, hey, you used your prescriptions, you stayed with adherence, you used the telehealth applications that are walking into the emergency room and creating actually little Pokemon Go, model of here's a bit of love, here's a coupon for a movie, here's whatever. And we actually had this crazy bit of math. Now, it took 3-4 years, but it was a remarkable amount of savings if we were just able to lower the morbid obesity number.
Yeah,
Am I making sense in trying to come
Yeah,
up
we
with a
have a-
unified?
we have a paper coming out on the productivity. So, at a macro level, productivity in retail was about 1.6, 1.8% per annum. It's up to about 3.7% per annum from barcodes, checkouts, self-checkout, all these things. I mean, they've really worked overtime to optimize productivity. Healthcare, we're doing great. We're at second lowest to education. And then after $38 billion of health IT, plus whatever the private sector put in, we're almost at the same place.
Yes,
Yeah, but even if we just got to retail, we would save, I think, I forget the numbers offhand, it's somewhere around $2.3 trillion or $3.2 trillion over the next 8 years, and close to $800 or $900 billion in 2033.
How do I create a mechanism where, particularly a number of states are also have followed Arizona, of sort of have a capitated reimbursement model on Medicaid populations. So some of my payment issue, that hurdle is sort of already built in.
So I want a couple of things. So one, you said it took 3 or 4 years. No, but I'm
The
just
math
saying.
we said, it was
Yeah.
at least 3 years to really get
No,
the
I know, but
benefit.
how do I keep the patient in Medicaid on the rolls with the same? So in Nairobi, Kenya, one of our former students set up a company that was actually was an electronic data interface between health plans and hospitals. And in Kenya, everyone turns over their health plan every year, but they had biometrics on every single person that was in the health plan to prevent fraud. And so over 6-8 years, the platform has everyone's data. So it doesn't make a difference which carrier you have. Like, there's continuity. So that was,
Think about that.
yeah, so, and then the other thing is capitation's great. We've been talking about subscription models. So for these digital services, it's more like Netflix. Like, Netflix doesn't care how much digital content you consume, right? So if you want to consume more, here's a smorgasbord. Capitation was when it was in person and
Now, would you do that with a state insurance contract, not necessarily a Medicaid population?
You might even think about, here, I'm going to give you a subscription to these digital health tools. You could do it for everyone in the state. Everyone has this new digital service that Arizona Digital. January 1, we're going to help you figure out your cancer screening for the year. We'll help you figure out, here's 3 different checkpoints. You can plug your ring into it. And basically, you'll get these digital services as a baseline. It'll stay as you against your biometrics. So if you change your carriers, your data doesn't disappear. You know, if we really want to think outside the box, that Estonia does that with blockchain electronic personal health records.
It's the one thing I do have an expertise on is distributive ledger.
But, you know, I do think the math really should drive us to like crazy things, but that's totally doable. And it wouldn't be that expensive. I mean, even if the state spent, you know, pick a number, yeah, if that's going to help me over 3-4 years on Medicaid, but by doing this, you know, the health plan has no incentive to do this because you're not going to be there next month and you're not going to be there next year. Why do I care?
My fragmentation problem, this portion of my population's on private, this population's on Medicare, this is Medicaid, Indian Health Services, state employee, university employee.
But
They're
Ben,
all-
but you're trying to bring it up the diffusion of innovation curve, right? You need to
Yeah.
get enough critical mass, enough usage by the early adopters, by the folks who are really excited and are buying into it, right? It's not gonna be 100% of people who would do a subscription model. It's gonna be the 10 to 13% who are really excited about it. But that starts to diffuse as you start to see certain models win, right? That have the best product market fit. You're gonna see those start to win. So then you're actually gonna get out into the majority of the market. And that's where you drive the biggest cost savings. But it's not gonna be instantaneous, but the sandbox is your way to jumpstart it. Is your way to build that momentum.
How much on this, in that sort of what's in scope of the sandbox is changing incentives for incumbents or decision makers versus enabling new technologies to start?
It's actually brilliant because my personal experience has been incumbents do their best to stop innovation.
Yeah.
And it's like there's some brilliant wearables and technologies, and because they don't own an army of lobbyists or aren't part of an association, they're stillborn.
I wonder if some of the policy framework is really, you know, we think a lot about utility incentives for what makes them adopt new things and what makes them stop things, and that's a big part of the barrier. And so could you pilot, actually the utility is going to get paid differently for the next 4 years? Does that change what can come forward? Or
I know there's been a number of experiments over the last 25 years where if a utility got this much more efficient, their retained earnings, this private utility, were actually grew. So if you lowered your costs by efficiencies, we actually let you retain more. So it's the seesaw effect. I guess you could do that with a number of products. And we have issues, everything from fire insurance to other types of products where we need to, you know, the current model isn't working. The peanut butter spread model.
fire tech adoption is a whole other, that's like incredibly fragmented market mostly, and no clear drivers to get technologies to scale.
God, I wish I could elect all of you to Congress and then get rid of everyone else. It might take us a couple months, but we could solve the nation's problems. A personal fixation. So every year, my little girl and I, we go up to the Navajo Nation. And because I have a fixation on digital health, telehealth. I don't like telehealth anymore. I call it digital health now because I want to talk to an avatar and not a human. Sorry. And so we've been, like last Christmas and the year before, we went out and put up Starlinks and Wi-Fi repeaters around the chapter house. What's the next generation of, hey, the medical clinic, it's in the middle of nowhere that basically has a PA, can use certain technologies where we had a company in Scottsdale a couple years ago, and then COVID sort of wiped out their model. They were in a couple, you'll love the irony, abandoned Theranos clinics and Safeway grocery stores, but it was an automated healthcare clinic. You came, you signed in yourself, you picked up this thing, you showed, and you stuck your arm in, blood pressure. How close are we?
So a few things. First of all, you're totally right that communications, really great communications is going to underlie, especially if there's robotic technologies involved. Like there have been demonstrations, for example, of surgeries from, Europe to the US, but that was with a huge investment of a reliable communications channel. If you have your Zoom calls and you know how often those get dropped, yeah, you don't want anything like that for a sort of real-time robotic interaction. But that's all assuming that it's being remotely controlled by a human. And there is a lot of amazing work in terms of interventional procedures that are being done. So the ARPA-H is now sponsoring some really spot-on projects to, I think, treat some conditions where it's not even just that you don't have to wait for a human surgeon. It's just that the system can do it at a scale of time and space that is just better than what people can do. So for example, getting really deep into the brain to treat strokes very, very quickly. So in terms of the remote and rural areas, I think it's going to have to be a path from remote teleoperation, remote communication that's going to rely on those communication channels, and then eventually to autonomy. Likely autonomy will still require great communication channels because you won't have all the data that you need locally. You will still need to communicate with other information held elsewhere. So I think the current bottleneck is actually communication, and then all the general challenges with AI. I'll just say one other thing that is something we have to get over. It's not really a regulatory thing, but a societal thing is right now all the conversation is about who's going to win the AI race by who's going to make the best models. I think the people that are going to win the race, whether it's AI or robotics, is going to be who can use it, right? Who can implement it? Who can improve people's lives? And for that, we're going to have to embrace it. And so if we have great examples of how this can improve, whether it's through digital wearables or through novel surgeries, we're making 3D printed hearts for heart replacement, the narrative has to be around the potential upside and not the scary discussion. Yeah, that helps. No, not at all.
Not a non sequitur, but last year I went to New Hampshire and they were growing undifferentiated islet cells. And they were also growing some kidneys in an experimental lab they had there. And it was a big scale. This wasn't Dean Kamen. So, how can he be that age and that energetic? But the concept of my morbid obesity population, after a few years getting their weights down, do I have to replace islet cells so they can produce insulin again? And if 33% of US healthcare spending is just diabetes, the amount of money if you could cut it in half. And it is shocking. We've done a couple presentations on disrupting diabetes as an office as the Joint Economic Committee of the amount of savings. And the diabetic community attacked us. As it turns out, having lots of sick people is how you get your paycheck. I'm sorry, I'm raising the level of cynicism, but and maybe there's where the think tank community has to help us sort of crush the morality of, saying the morality of disruption. There's a reason you didn't go to Blockbuster Video last weekend.
Yeah, I mean, I think the American public's interested, agitated right now about affordability of healthcare. And at some level, there's no there's no slogan about how to, what do you want? I mean, I want affordable healthcare. Like, what is it that I want out of the healthcare system? I mean, because we all see this, it's so deep in the weeds, like the alphabet soup of agencies, the alphabet soups of payers, who's responsible. I think, but it, one of the failures of the policy community is to not answer that question. I mean, this is a really critical time from the economic perspective, of what do we want, how do we help the American public articulate what they want? And how do we incentivize the delivery system to deliver value rather than better financial performance and bonuses for the CEO for driving up healthcare costs?
We need a disruption. I want you to be more aggressive. We need a disruption in the cost. I mean, when you're borrowing 95,000 a second, borrowing, the wheels are about to come off. And the idiot class, my kind, if I don't convince the bond market we're doing something to start to at least flatten the borrowing curve a little bit, horrible things are coming.
Yeah.
So we've done a lot of talking about healthcare, but the fact of the matter is a much more productive energy generation, my ability to, the number of lobbyists I get saying, I want more, medical slots. And yet we already see in some of our demographic populations, I don't have that many kids, sitting for the MCAT. We are going to have to do labor substitution, and I'm like a heretic doing these things. You're famous for some of this. How does an idiot like me start to convince policymakers, the public, another paper on bad regulations? How do I say, here's how you do smart regulations. Here's how to design a regulation that's future-proofed. Because tomorrow there will be a technology I never thought of. And that's where we got sort of giddy about the concepts of sandboxes, is it's the closest thing I had to sort of a universal future-proof, if that makes sense.
Yeah.
Absolutely. All right, so we have only a few more minutes. Tell my freaky smart kids, which I resent all of them for their youth and their IQs, what do I offer up? I get a run at September of another reconciliation bill that I'm sure I'll get screwed in this and they'll break their promises, but right now I have promises from leadership in the White House. I get one more run at trying to do some things disruptive. A lot of it was going to be healthcare. We're going to try to see if I can update some of the incentives in Medicare Part C and some of these other things. It's a spot where I can weave in at least a few policy ideas into something that goes on a reconciliation budget. What do you want? What do I do to at least make some progress?
I mean, I'll say that there's already momentum behind some of this accelerated coverage for breakthrough technology stuff, both the House and the Senate, bipartisan support. That's a great opportunity that's going to have impact. It would codify what rapid is and create a sandbox that would enable and incentivize innovators to create the type of applications.
Give me an idea. How would you write it? Just give me a sentence.
I think that legislation is already it's voted out of committee in the House, it's pending in the Senate. But the language is there. It's breakthrough technologies, get
Okay.
a period of.
I actually know the bill.
Yeah, those two bills.
Okay. So that would be
A
something
real
to try
life
to weave
sandbox that
into.
has already sort of on the drawing board.
We've talked about a lot of the ways in which we could future-proof regulations, like performance standards is a good way of boxing in what you could do that doesn't specify this technology that needs to be used to get there. But in order to drive the whole federal apparatus to embracing performance standards or sunset review or ex post analysis of efficacy, I think you have to just go to the very top. You want something big. Have the CBO start to incorporate the regulatory drag that already exists into their analyses. Right now, they'll look at if there's a bill that says they're going to reform regulations in some way, they'll score that, but they're not incorporating the drag that's already there into the baseline.
You've already written about this, haven't you?
I have, yeah.
I may be able to make that happen.
Then that creates the incentive to fix it.
Okay. If you had to change anything you're doing in Utah right now, because the one complaint I've had, and it's same thing with Arizona, is it's a lot of documentation to qualify for the sandbox. Is that true? Is there a way to make it better, faster, easier?
I mean, we've changed it since January. We've moved to a lot more informal discussion.
Okay, I did not know that.
So now we have, a simple intake form where they express interest, and then there's conversations. But I don't know how you scale that. I mean, it works in Utah because I know the people at the regulatory agencies, and there's 15 of them. At a federal level, it's substantially more complicated. I'm not sure what I would change, honestly, on ours. I think it has the potential to work really well. Well, okay, one thing that I think has actually worked well that you mentioned several times. I mean, they created, in addition to my sandbox, which is just a general regulatory sandbox, anybody can apply, they created the specific one for artificial intelligence, for AI. And one of the things I've learned out of this conversation is I know next to nothing about healthcare. And, I've got pages of notes. And so I would not be I would not be ideal for adopting the kinds of things that you guys are talking about. And so, maybe there's the argument here is for something that's not broad general, that these are very specialized kind of spaces, and that they should have specialized sandbox, that it should not be one size fits all. And I don't know if that's helpful or not, but I think, it's valuable to me to just see how these are very complicated, very complex issues. And I think all of the issues, energy is going to be just as complicated as healthcare is, and yet require a completely different set of expertise to do it right.
I'm actually optimistic about energy.
I am too.
Desperation is high. There's enough private sector pull that energy is, the logjam is breaking out of desperation.
All right. They're basically, I get the official note saying, stop talking. But they always write it so politely. Thank you for doing this. Don't want this to feel like I wasted your time. Let's first do the dour part. I'm intensely worried because the math is getting uglier faster than even I expected. I am pathologically optimistic. I'm 64 with a 4-year-old, and my wife's my age. So I have to believe, it's just, I don't want us to go through a cycle of misery to be able to make changes. And look, you're all geniuses. Look where we're sitting. Help us, because the intellectual acumen of Congress has basically chased away. You've seen it. You've been there. He used to be part of our team. We've chased away smart people because it's so absurd. If any of you have ever sat through been a witness in an actual committee hearing, I need my 5 minutes for YouTube, and then I'm gonna say insane things, and then I'm gonna get up and walk out. The model doesn't work in Congress anymore. But maybe the opportunity to move some language that allows you to weave through and do something. So we have sandbox, we have reimbursement, we have speed of getting the right to try it. I'll take any ideas you have.
We had a commission like 20 years ago. There was a commission that was looking at the balanced budget.
Yes,
Yeah.
Sarbanes,
Yeah, I mean,
Yeah.
we should
we got very close.
do another one. I mean, at least it gets it public.
I have tried year after year after year after year to do all-in debt commission. The political class is terrified, both on the left and the right, to tell the public the truth. How do you get in front of a room and say, it's not people across the border, it's not that we're not taxing wealthy people enough, it's demographics. We just don't, we've gotten, and when the mantra from both sides is no one ever got unelected by spending too much money, you laugh. I've actually had the last 2 presidents functionally say that to me. I do everything I can. We all do. But never miss an opportunity to explain the morality of the disruption of the technology you're bringing is if we don't have a radical change in both spending and productivity, it comes crashing down. And it doesn't crash, it basically rots, which is even actually more dystopian. Thank you for hanging out with us.
Thank you
And-
for coming out.
Inviting us.
Yeah, and I would give you all wonderful parting gifts, but they don't put that in my budget.